Everyone. This is Dr. Kamal, and today we'll talk about a very important and common topic that we encounter mainly in patients in the hospital, which is hyperglycemic emergencies or diabetic emergencies between diabetic ketoacidosis or DKA and hyperosmolar hyperglycemic state, or known as HHS. So, we'll talk more about the diagnosis and the management and the updated guidelines. So it will be more advanced topic that we'll talk today. So just some numbers to start with. There's around 500K US hospitalizations per year for diabetic ketoacidosis and HHS. The mortality is around 1% for DKA, and it's around 5 to 20 for HHS. Um, so mainly, the main reason that the mortality of HHS is way more than DKA is mainly because of the patient profile. So in DKA, it's usually a complication of type 1 diabetes. So those patients usually are younger, in the 30s or 40s. So they have less comorbidities, less risk of hypertension or cardiovascular disease or kidney disease. While on the other side, when we talk about HHS, it's usually a complication of type 2 diabetes. So those patients are usually older, above 60, above 70. So they usually have hypertension, CKD, other cardiovascular comorbidities. And the second thing, the DKA, the main mortality that comes from the DKA, it's mainly because of the acidosis. While on the other side, the HHS mortality is coming from the hyperglycemia that's causing a hyperosmolarity and severe dehydration. So those patients in the HHS is usually very dehydrated, which can affect a lot of other organs like CNS, or causing a hypernatremia or causing AKI. So this usually the difference in presentation between both. So let's start first with an opening case, which I wanted to start with because this is the first priority, whether you are treating a patient with DKA or HHS. So let's dive through the clinical vignette. So here we have a 19-year-old male, type 1 diabetes, with 2 days of polyuria, polydipsia, nausea, vomiting, and abdominal pain. So signs and symptoms of um, DKA. He ran out of insulin 3 days ago. BP 95/60, heart rate is elevated, respiratory rate is elevated, temperature 37.8. He's lethargic with fruity breath. So classic case of DKA, and we have here the glucose 520, the pH 7.18, and the bicarb is 9. So the patient is hyperglycemic, the patient is acidotic. We have the sodium of 131, potassium elevated at 5.9, and there's a 9 gap of 28. The beta hydroxybutyrate is 6.8, which is very elevated, BUN 38, creatinine 1.9, while the baseline of this patient is zero point 0.9 of creatinine. And when we look at the urine, it shows 3+ ketones. So this is a very clear classic picture of DKA. And usually what the question asks here, what is the first immediate action? Start insulin, start bicarb, give IV fluid, check potassium first, then treat accordingly. So always it will be fluid first, IV fluid first. So we'll give IV fluid resuscitation. The type of the IV fluid that we can give is zero point 0.9 normal saline, or LR is fine as well. So we'll give a bolus of 1 liter over the first hour. Then we'll talk after that about maintenance. So here we need to know that the life-threatening comorbidity or the life-threatening part of the DKA or HHS is usually volume depletion. So resuscitation here comes first before starting to correct the DKA or HHS. And always don't start insulin before checking the potassium, and if needed, to correct the potassium before starting the insulin. And bicarb is not indicated at a pH of 7.18. Usually the threshold is 6.9. So this is just a case to start with, and the main point of this case is IV fluid first before anything, right? So let's go through this. So let's talk about the definition of DKA versus glycemic osmolar state. So in DKA, it's come from the name diabetic. So they will have hyperglycemia, ketoacidosis. There will be ketone bodies causing acidosis, and the type of acidosis here will be high anion gap metabolic acidosis. So the glucose will be over 200, and this is very important because it used to be 250 as a criteria for DKA, but now it's 200, and even it can be below 200 that you can see in aglycemic ketoacidosis, which you can see in SGLT2 inhibitors, pregnancy, some fasting state. So they become less restrictive about the glucose criteria here. Then the acidosis part, it will be pH below 7.3 or serum bicarb below 18. The criteria before they used to put the anion gap in the criteria, but it's not anymore. We'll talk about this later. Then we have the ketones. So the ketone that's very specific to the DK is beta hydroxybutyrate. So beta hydroxybutyrate above 3, which you can detect in the blood, or if you want to look in the urine, you will see urine 2 plus ketones. Then you have the anion gap. The anion gap will be elevated. Again, it will be high anion gap metabolic acidosis. This is useful for the diagnosis, but it's not no longer required, as we'll talk in the next slides. Then we have the osmolality. So the osmolality here is variable and can be normal. And remember, the osmolality depends on sodium, glucose, and BUN. So here the glucose, it can be elevated, yes, but it's not severely elevated to cause hyperosmolality. It can definitely cause hyperosmolality, but not necessarily. And usually the sodium here would be hyponatremia versus here you can see hypernatremia as we'll talk. The onset of the decay, it's more acute, so it's usually hours to 1 or 2 days. And usually it's associated with type 1 diabetes, but also it can happen in type 2 diabetes. And the main risk in the DKA, it's not the glucose, it's more the acidemia, the acidosis here, right? On the other part, we have the hyperosmolar hyperglycemic state. So this is comes with hyperosmolality, right? So here we'll see the osmolality usually more than 320, and this is effective osmolality. And the reason we say effective, because for example, if you have increase in the osmolality because of BUN, BUN is not effective osmol, which means it will not draw water outside of from inside the cells to outside, which is the opposite in case of hypernatremia or hyperglycemia, which comes with effective osmolality, which means it can draw water from the cells from inside to outside. So if you have a cell here and you have high glucose or high sodium outside, it will draw the water from inside to outside, and that's the main risk here in the hyperosmolar hyperglycemic state. And the reason it causes hyperosmolality versus the DKA, because usually the glucose levels are very high. It's usually above 600, right? And here, those patients, they don't have acidosis usually, so the pH more than 7.3 and the bicarb usually will be above 18. And again, there's no ketones, or if there is some ketones, it will be mild. So for example, the beta hydroxybutyrate will be less than 3. In the opposite here, if we talk about DKA, we said it's usually above 3 and can be even 4, 5, 6, etc. And the 9 gap in the high HHS, usually normal or mildly elevated. The onset of the HHS, it's more subacute, so it takes days to weeks, versus when we talked about DKA, it's usually more acute, hours to 1 or 2 days. HHS is primarily in type 2 diabetes, so you'll see it more in elder population. And the main risk of the HHS is not the acidemia, because there is no acidemia to start with. It's more about the severe dehydration that's coming from the significant increase in the serum glucose. And this severe dehydration can cause multi-organ failure like AKI, CNS signs and symptoms, and even thrombosis, because if you think about it, the blood is very thick, and this can cause sometimes, thrombosis. Sometimes there's an overlap. We call it mixed DKA HHS, which can occur in 30% of the patients. And here you'll see ketosis, but also you'll see significant hyperosmolality. And the way you treat it is the same. As we'll talk, there's minor differences between treatment of DKA versus HHS. If we come to pathophysiology, because I love pathophysiology, so the main pathophysiology, whether DKA or HHS, we have some insulin deficiency, and on the other side, there is counter-regulatory hormone increase. So if you have insulin deficiency, which you can see absolute in type 1 diabetes or relative in type 2 diabetes, if the insulin is low, that will stimulate the other counter-regulatory hormones like glucagon, like cortisol, epinephrine, and growth hormone. Um, so the combined effect between decrease the insulin and increase the counter-regulatory hormone will be unopposed catabolism that will lead to DKA and HHS. So first, you have glucose dysregulation. You have increase in the glucose in the plasma and decrease the uptake of this glucose, because some of the organs, like muscle, lipose tissue, they have GLUT4 receptors, which is insulin dependent, right? So you have increase in gluconeogenesis. The liver make glucose from the amino acid and the lactate, and this amino acid, remember, we are in a catabolic state. So there is increase in the breakdown of the proteins in the muscles and different parts of the body that the liver used to create glucose. On the other side, you have also increase in the glycogenolysis, which is mainly glycogen breakdown to glucose. So that's the second mechanism of increase the glucose. And on the other side, you have decrease in the glucose uptake, especially in the peripheral tissues that cannot utilize the glucose without the insulin. So between these three different etiologies, we have severe hyperglycemia that can cause osmotic diuresis and severe dehydration. The other part, we have the ketosis, which is DKA specific because there is no ketosis in the HHS, or it can be mild. So we have increase in the lipolysis, again, because you don't have enough insulin. And this lipolysis ends in free fatty acids that goes to the portal circulation. Then after that, you have increase in the beta oxidation of this fatty acid that converts to acetyl-CoA, and the acetyl-CoA get as a product to create more ketones, which is the ketogenesis process to create different types of ketone bodies like acetoacetate, beta hydroxybutyrate, and acetone. All these different ketones will cause metabolic acidosis with an ion gap. So what is the end product? The end product, you have severe dehydration. This dehydration, usually in average, it's about 3 to 6 liter deficit, which will cause osmotic diuresis. So those patients usually have the polyuria and the polydipsia part. Then you have also electrolyte loss with the diuresis, so you can see some potassium abnormalities, sodium, magnesium, and phosphate, and there is total body depletion of these electrolytes. So even if you see a patient with DKA who has hyperkalemic state, the potassium is 5.7 or 6 or 7, usually they are depleted intracellularly from the potassium. And also you have CNS effect. The CNS effect is usually more in the HHS because it's the same as hypernatremia. You have very high osmolality, usually more than 320, which cause a switch of the water from the brain cells from inside to outside. So usually the CNS effects is more in the HHS, but also you can see it in the DKA, which comes in the form of irritability and lethargy. But HHS, it can be coma. And on the other side, you have hypercoagulation state because you have hyperviscosity because of the glucose that can increase the risk of DVT and PE. So it's very important that those patients have some kind of DVT prophylaxis, whether Lovenox, whether heparin, or if they are on Eliquis or any anticoagulant, don't stop those kind of medications because they are on a higher risk of DVT and PE. So again, all this pathology, it started with insulin deficiency. So insulin deficiency drove all these different metabolic abnormalities. So to if I want to summarize this, we have insulin deficiency at the very start and dehydration at the end. So the management will be mainly insulin and fluid. This is the cornerstone of the treatment. Okay, so we said we have DKA, which is diabetic, which is high blood glucose, and there's also ketosis, and there's acidosis. So before just blaming this on DKA, you need to put a differential for uncontrolled or high glucose, differential diagnosis for the ketosis, and differential diagnosis for the metabolic acidosis. So let's start with a differential for hyperglycemia. Again, we'll talk mainly today about the DKA or HHS, but another possibilities would be uncontrolled diabetes or stress hyperglycemia. So those are the four differentials for hyperglycemia. So glucose between DKA, it's usually above 200, which is part of the diagnostic criteria. HHS is usually above 600. If it's uncontrolled diabetes, it's usually the range between 200 to 400. Stress hyperglycemia, if someone is taking like high doses of steroids, that can cause also stress hyperglycemia, which is acute hyperglycemia. So the range of glucose will be between 140 to 250. Okay, so from these, we see that the most state that has severe hyperglycemia will be the HHS. So if you see a blood glucose above 600, you have to um, like consider it's HHS until proven otherwise. Then when it comes to acidosis, acidosis is mainly in DKA, right? So the pH will be below 7.3, the bicarb will be below 18. In HHS, you don't have acidosis, so pH will be above 7.3, and also in uncontrolled diabetes and stress hyperglycemia, you don't have acidosis. The ketones, the ketone mainly in the DKA will be beta hydroxybutyrate above 3. In HHS, it will be absent and maybe some trace. And when I say trace, it can be 1 or 2 of beta hydroxybutyrate. In the uncontrolled diabetes and the stress hyperglycemia, there will be no ketones. When it comes to the osmolality Again, as the name indicates, hyperosmolar hyperglycemic state. So the hyperosmolarity will be mainly in the HHS, right? The 9 gap will be elevated in the DKA. And why it's elevated? Because of the ketones. The ketones are anions, so that you'll have high anion gap metabolic acidosis versus HHS or uncontrolled diabetes or stress hyperglycemia. It will be mainly normal anion gap. And when it comes to the onset, again, DKA will be hours, it can take up to 1 or 2 days, but HHS is mainly, um, it can be prolonged onset, usually days to weeks. In uncontrolled diabetes, it will be chronic or gradual, and we are talking about weeks to even months. Stress hyperglycemia, it comes stress, so it's more acute, right? So you'll see it with like illness or some kind of surgery. When it comes loss of consciousness and the CNS side effects, it's milder in the DKA than the HHS. So usually those patients can be alert, but also can be lethargic, while in HHS, it can lead to coma. In uncontrolled diabetes or stress hyperglycemia, usually they are alert. Dehydration, the most dehydration will be in the HHS because again, this severe significant hyperglycemia we talked about will cause severe osmotic diuresis. So here we have profound dehydration. Usually the water deficit is more than 9 liter. Then secondly, in the DKA, they'll have some dehydration moderate to severe, but in the uncontrolled diabetes or the stress hyperglycemia, the dehydration is mild to minimal. Um, Diabetes history, DK is more associated with type 1 diabetes. HHS is more associated with type 2 diabetes, while in uncontrolled diabetes, it can be type 1 or type 2 uncontrolled. In stress hyperglycemia, they are not diabetic to start with because if they are diabetic, then it will be more uncontrolled diabetes, or sometimes it can be mixed picture between uncontrolled diabetes and stress hyperglycemia. The treatment of DKA, mainly IV fluid. These patients will need insulin, and also um, initially they can be hyperkalemic. Then after that, the potassium will drop, so they will need some potassium. In HHS, mainly it's IV fluid, and sometimes with just IV fluid, even without insulin, their glucose can normalize. And you don't want to decrease the glucose suddenly and very fast, so you're always starting slow decrease in the glucose. In uncontrolled diabetes, they just need to adjust the insulin. Here, the insulin is mainly IV insulin, regular insulin, but here it's usually will be subcutaneous insulin, whether it's fast acting or long acting. In stress hyperglycemia, you mainly want to treat the underlying cause. So this is the differential diagnosis for the hyperglycemia. Let's talk about differential diagnosis for ketoacidosis, and briefly we'll talk about the ketone types. So differential diagnosis for ketoacidosis will be DKA, or alcoholic ketoacidosis, which is AKA, or starvation ketosis. So from all these three conditions that can cause ketoacidosis, you will only see high blood glucose in the DKA, right? In alcoholic ketoacidosis, you will have low to normal glucose, so usually the range is between 50 to 200. But in starvation, it's usually low, but also it can be normal, which the name come from starvation, so you can expect some hypoglycemia. Um, in DKA, they are acidotic, right? In alcoholic ketoacidosis, they're also acidotic because remember, whether it's like, different types of alcohol like ethylene glycol or some glycols can cause some acidosis, right? In starvation ketosis, they might have mild acidosis, but usually they have normal pH. When it comes to the bicarb, so the bicarb will be below 18 in the DKA. Again, they have acidosis. In the alcoholic ketoacidosis, they have also low bicarb because they have acidosis. In starvation, it can be normally all slightly low, so it can be maybe like 19 or 20. The ketones in the urine, in DKA, it's usually 3 plus. In alcoholic, it will be trace or negative. In starvation, it usually mild, so 1 or 2 plus of ketones. Um, the beta hydroxybutyrate, which is a test of the blood, you look at the blood levels of beta hydroxybutyrate, usually in DKA, it's above 3. In alcoholic, they can have also very high or elevated beta hydroxybutyrate. In starvation, it's very mildly elevated. Anion gap, anion gap will be elevated in DKA, elevated in alcoholic ketoacidosis, but normally normal or mild elevation in starvation. History, DKA, they will have insulin omission somehow. There have been missing insulin doses and they have diabetes history. And usually it's triggered by an illness, right? In the alcoholic ketoacidosis, the history will be someone with alcohol use disorder, but also poor intake. In starvation, ketosis would be prolonged fasting. So some people who was like following a keto diet, sometimes we get this from the history. Hey, I started like keto diet. I have been eating like low carbohydrates and all that. That would be more consistent with starvation keto acidosis or ketosis. So the key clue in DKA will be diabetes history, and they have some kind of like hyperglycemic signs and symptoms like polyuria or polydipsia. In the alcoholic ketoacidosis, you can check the ethanol level, and these patients sometimes have vomiting, and again, they have normal glucose. They don't have hyperglycemia. In starvation ketosis, they don't have diabetes, right? And you might see like some weight loss if they've been following some keto diet, or they have been starving, or they have been having prolonged fasting. Um, we can check for different ketones in between the blood and the urine. So beta hydroxybutyrate is a quantitative, which means you can count it. That's why we said it's above um, 3 when we talked about the DKA. Um, Acetoacetate and acetone, it's mainly in the urine. So acetoacetate, for example, it's a urine dipstick, so it's more qualitative than quantitative. It just says um, if there's acetoacetate or not, and usually it will be 1 plus, 2 plus, or 3 plus. So again, beta hydroxybutyrate, because it's a blood test and it's quantitative and it's specific, so it's preferred and more accurate in the DKA. So 90% of the ketones actually in DKA is beta hydroxybutyrate. Previously, beta hydroxybutyrate used to be just diagnostic, has diagnostic values. So you check the beta hydroxybutyrate at the beginning to diagnose DKA, and that's it. But now um, the trend is more using the beta hydroxybutyrate as a target for treatment. So if you are starting treatment for DKA and the DK, you check the beta hydroxybutyrate and the 3 or 4 or 5, so usually it can be a target of treatment. So you target beta hydroxybutyrate less than 1, and this can indicate some resolution of the DKA. So um, again, if you're checking ketones, beta hydroxybutyrate um, will be the test you go for. And this is really important in um, alcoholic ketoacidosis. You do a urine dipstick and you found it negative, also, although this patient can be ketotic. And the main reason is when you check the urine, you are checking for acetoacetate or acetone. But actually, the type of ketone in the alcoholic ketoacidosis is mainly beta hydroxybutyrate. So if you do a urine test, you're checking for the acetoacetate or the acetone. You sometimes you can get false negative, or you can get negative because you cannot test for the beta hydroxybutyrate in the urine. So we talked about differential diagnosis for hyperglycemia. We talked about differential diagnosis for ketoacidosis, and we talked briefly about the ketone types. The next one, we'll talk about differential diagnosis for the high anion gap metabolic acidosis. So differential diagnosis for high anion gap metabolic acidosis. So first, we need to have acidosis, which will be pH less than 7.3 from VBG or ABG. Then the metabolic part, which will see serum bicarb less than 18. And always remember, serum bicarb is more accurate than the actual bicarb you see in the VBG, because the bicarb that you see in the serum, it's measured directly, while the bicarb that you see in the VBG or the ABG, it's usually calculated. So the serum bicarb will be more accurate. So you have acidosis, you have low bicarb, that's we call it metabolic. Then you calculate the anion gap and you found it more than 12. So the anion gap, the way you calculate it, it will be sodium, which is the cation, minus the anions, which are the chloride and the bicarb. And the normal anion gap will be 8 to 12. High anion gap defined as an anion gap more than 12. And again, if this patient's having hypoalbuminemia, you have to correct the anion gap for the albumin. So for each 1 point decrease in the albumin, you increase 2.5 to the anion gap. So if someone having, you calculate the anion gap and it's 10 per se, and you check the albumin and the albumin is 2. So albumin is 2, so it's 2 points below the normal range, which is 4. So what you do is you add 2 multiply 2.5 to the anion gap. So if you have albumin of 2, you add 5 to the 10. So 10 plus 5 will be 15. And here's the importance of this. Sometimes you can calculate this and you find it normal anion gap between 8 and 12 at this in this case. But when you correct it, you find it's high anion gap. So it's really important to check the albumin and correct the anion gap for the albumin. And the mnemonic that you can use for differential diagnosis for high anion gap metabolic acidosis, it will be MODPILE's mnemonic, or the more comprehensive one will be gold mark. So if we use the MODPILE's mnemonic, so M for methanol, U for uremia, D is DKA, P propylene glycol, I iron H or iron, L lactic acidosis, E ethylene glycol, S salicylate. So you need, if you have suspicion for any of these other conditions, you have to exclude it. And please refer to the other video that we talk about acid-base disorders and high anion gap metabolic acidosis. You will see very comprehensive explanation of these differential. And for any high anion gap metabolic acidosis, you need to check the delta ratio. And this is critical for mixed disorders, because sometimes if they have infection, or they are vomiting, or they having diarrhea, or they are COPD, having respiratory as like different metabolic disorders, you need to check for that. So the formula that you check the mixed metabolic disorders will be the delta ratio, which is the difference between um, the change in the anion gap over the change in the bicarb. So you have the measured anion gap, let's say it's 15, so it will be 15 minus 12 over 24 minus the measured bicarb, let's say it's 16. So for example, if we want to just to simplify or explain, change in the anion gap will be 15 minus 12. So 15 is the calculated anion gap minus 12 over the 24 minus the bicarb that you see on the BMP. So 24, let's say minus 16. So here it will be 15 minus 12 equals 3. 24 minus 16 will be 8, right? And based on this ratio, you can interpret it, right? So if the ratio is below 0.4, this will be pure non-anion gap metabolic acidosis. This is not even high anion gap, and you need to check for other etiologies for metabolic acidosis, whether it's diarrhea, whether it's RTA, or if it's even IV saline. If the range of the delta ratio between zero point 0.4 to 1, this is a mixed disorder, so it's mixed high anion gap metabolic acidosis plus non-anion gap acidosis, which you can see sometimes in DKA. We usually start those patients on normal saline, so the normal saline can cause hyperchloremia and normal anion gap metabolic acidosis. Um, if the delta ratio is between 1 to 2, this is usually pure high anion gap metabolic acidosis, and this will be the expected range if it's pure DKA without any other types or etiologies for acidosis. If the delta ratio above 2, then usually you have high anion gap, but also you have metabolic alkalosis, and you can see also this in DKA if the patient is on diuretic or they having vomiting, right? And this is important also because in DKA, usually it's high anion gap, as we said, so the delta ratio will be below 1. Um, but if you're, sorry, the delta ratio between 1 and 2, but if you see the delta ratio is dropping, that can be concerning for hyperchloremic acidosis, which is normal gap acidosis, and this can be from the NS, the normal saline resuscitation, and this in this scenario, you will need to switch to LR instead of the NS. So this is just a differential diagnosis for hyperglycemia, ketosis, and also acidosis or metabolic high anion gap metabolic acidosis. So let's dive deeper into DKA diagnostic criteria, and this is the updated criteria. And I'll try to tell you like what unchanged in this criteria from the updated criteria. So D, diabetes and hyperglycemia. Again, it used to be 250, but now it's 200. And even it can be below 200 if we are talking about aglycemic ketoacidosis, the glucose even can be below 200. So this is the D part. The K part, it's ketonemia or ketosis. And the preferred way to look for the ketone bodies will be the blood beta hydroxybutyrate. Remember, beta hydroxybutyrate represents almost 90% of the ketone types in the DKA. So beta hydroxybutyrate, you can get it as it will be more than 3. If you don't have this available and you just want to check the ketones, you can check the urine ketones. But remember, the urine ketones, the dipstick that you do, it usually looks for acetoacetate. It doesn't check for beta hydroxybutyrate. So again, point of care beta hydroxybutyrate is more preferred over the urine ketones because it's more specific. So this is the D part, K part, then the acidosis part. The acidosis criteria hasn't changed from the previous guidelines or the previous criteria. So you have arterial or venous pH less than 7.3 and or bicarb less than 18, which means if you get a BMP and you find bicarb less than 18, that's acidosis. Um, you don't have to get a VBG to confirm it. So if you just have the bicarb as below 18, that's acidosis. So serum bicarb remains the key marker. And again, remember the serum bicarb is more accurate than the VBG or ABG bicarb. The last part is the bicarb low. So again, if you're having metabolic acidosis, the bicarb will be low. A major key change is the anion gap. So the anion gap removed as a required criteria because usually those patients they have a lot of things going on, and they can have different types of acidosis. They can be infected having lactate and they have ketone or vomiting or having diarrhea or using diuretics. So sometimes they have just mixed metabolic disorder. So just relying on the anion gap can be unreliable. The second change is the glucose threshold, which dropped from 250 to 200. But also, again, remember the aglycemic ketoacidosis, you can find the glucose even below 200. And then the third change is the beta hydroxybutyrate. Beta hydroxybutyrate above 3 is diagnostic for ketoacidosis or ketosis. So this will be the preferred. And why is preferred? First of all, you can get it point of care. Second, it can be quantitative, so it can give you an actual number, and this can indicate the severity of the ketoacidosis. If it's 3, it's very different than being 7 or 8 or 10. So, these patients are more severe. So you need to um, um, consider that when you are having or checking the ketosis. And again, it's more specific because, as we said, in DKA, 90% of the ketones that you will find will be beta hydroxybutyrate, and beta hydroxybutyrate you cannot check in the urine. Then here we have the HHS criteria, diagnostic criteria. But before that, there is a DKA severity classification between mild and moderate and severe. And why it's important? Because mainly of this, where to treat these patients. If you having a patient that you are treating in the general floors or the ED, usually it's mild DKA. And if it's severe, these patients need ICU monitoring and ICU uh, management. So in mild, pH will be between 7.3 to 7.25. In moderate, it will be 7 to 7.24, and severe will be below 7. The bicarb here will be 15 to 18, here 10 to 15, and here below 10, which is makes sense because they are more acidotic. Beta hydroxybutyrate in the mild state is between 3 and 6. In the moderate is between 6 and 10, and in the severe state, it will be more than 10. I think the highest BHB that I've seen was 20. So this is consistent with severe acidosis. And the glucose, it doesn't matter. So the criteria here, again, DKA, the risk of mortality of DKA is mainly the acidosis part, it's not the glucose. So if they are having glucose 200, 250, 300, 400, it doesn't change the severity of the DKA. Mental state, usually in the mild, there will be alert. In the moderate, alert can be a little bit drowsy. In the severe state, they can be in coma. And again, this is important because the severe DKA will need ICU monitoring. The HHS criteria, again, it's hyperosmolar, hyperglycemic. So hyperosmolar, the osmolality will be above 320. Hyperglycemic, so the blood glucose will be above 600. Again, those patients, they don't have acidosis, so the pH is above 7.3. They don't have ketosis, so the ketones will be absent or trace. And remember, the osmolality equation, it's 2 multiply sodium plus glucose over 18 plus BUN over 2.8. We don't care about the BUN because it's ineffective, which means it cannot cause water shift intracellular and extracellular. Mainly it's the sodium and glucose that we call effective osmoles. So that's why these patients are severely dehydrated. So sometimes you can see mixed DKA and HHS, which you can see in 30% of the cases. So here you will see high blood glucose, with ketosis and high osmolality. So here you need to treat both components. You need to treat the hyperglycemia with the hyperosmolality, but also to treat the acidosis. And these patients, as we talked, we will start with aggressive fluid resuscitation even more than the pure DKA. And we will monitor the beta hydroxybutyrate and monitor the osmolality for these patients. If you are having severe hyperglycemia, that can cause hyponatremia, which is not true hyponatremia. So sometimes if the blood glucose above 500 specifically, you need to do sodium correction, which you're adding 1.6 of glucose, 1.6 of sodium for each increase of 100 of glucose. So let's say the glucose is 300. So anything above 200, so the glucose went from 200 to 300. So this is 100-point increase in the glucose. So you add 1.6 to the sodium. So if the sodium is 130, the corrected sodium will be 131.6. Why? Because you have 100 increase in the glucose, and that's how you correct the sodium. Okay. Let's talk about the signs and symptoms of DKA and HHS. In DKA, they have hyperglycemia, right? So the hyperglycemia will cause osmotic diuresis. So these patients will have polyuria, polydipsia, and blurry vision. These patients will have ketosis, so they will have some nausea, vomiting, and abdominal pain. And the reason here, it's a compensatory mechanism to try to induce some vomiting to correct the acidosis, because again, remember, the vomiting causes metabolic alkalosis. So if you have severe metabolic acidosis, the body will compensate by vomiting to cause some kind of metabolic alkalosis to compensate for the acidosis. Also, another compensation for the acidosis will be respiratory alkalosis, which is mainly increase the respiratory rate, which will be deep and rapid breathing that we call Cosmo breathing to compensate for the metabolic acidosis. Those patients will have fruity acetone breath as well because of the ketosis, right? This is the fruity breath is coming from the acetone. These patients again will be dehydrated, so will have dry mucosa. They have poor skin trigger. They'll have tachycardia and sometimes hypotension, but usually they are not in shock. Neurologically, they'll have headache, lethargy, confusion, and coma in severe cases. Sometimes the trigger for DKA can be infection, and if that's the case, you will find fever, but DKA by itself is not a febrile disease. So if someone coming with DKA and they have a fever, look for their lactate, get blood cultures, and look for any source of infection. GI-wise, they will have vomiting. Again, vomiting here is because of the ketosis and the acidosis. And this vomiting, though these patients are having polyuria, so they are peeing a lot. When you add the vomiting to the polyuria, this will worsen the dehydration. Again, because of the vomiting and because of the low insulin, that will cause intracellular shifts. So usually you'll see high potassium initially, but after that, you can see hypokalemia. But actually, even if you see hyperkalemia, usually it's coming from the cells. And remember, most of the potassium in our body inside the cell, not outside. So this potassium they have outside, which is the hyperkalemia, they are getting it from the cells. So there's intracellular shift that's causing the hyperkalemia. So even if you see hyperkalemia, they have total potassium in the body low. If we go to the other side with the HHS, the typical presentation of HHS will be extreme hyperglycemia. The hyperglycemia will be more than 600, which will cause massive osmotic diuresis, even more than the DKA. So these patients will have profound dehydration, even more than DKA, usually 9 to 12 liters deficit. So they will have sunken eyes, orthostasis, and shock. again, we said that dehydration DKA is not usually severe, even if they have hypotension, they are not usually in a shock state. But in HHS, they can present with shock. Again, the neurological side effects are usually more profound in HHS. So you can see confusion, focal deficit, seizures, and even coma. They don't have acidosis, so they don't need to compensate. So you don't see the cosmal breathing here because, again, they don't have acidosis. And you will not find the fruity breath as well because they don't have ketones. And if they have ketones, it will be minimal ketones or trace. And remember why HHS having more mortality than DKA, because these patients usually elder population. So they will have different comorbidities um, as elder population, and also they are more dehydrated. Um, Precipitant infection. So again, the trigger for DKA or HHS is usually the most common one will be infection. So infection is the first or most common trigger for both DKA and also HHS. So if a patient coming with DKA or HHS with a fever, you have to look for infection. So you can get CRP, you can get procalcitonin, you can get lactate, you can get blood cultures. If you are suspecting UTI, you can get urine cultures. If you're suspecting pneumonia, you can get chest X-ray, and so on. So if they have a fever, you need to do some infectious workup, as we'll talk about. And because of the hyperosmolality here, and those patients are usually having hyperviscosity, so they have increase in the thrombosis risk and increased risk of DVT and PE, so they will need some DVT prophylaxis, whether it's subcutaneous heparin or subcutaneous Levodox.